me see if I can get this screen to share. Well, welcome everybody. If you have been with us before, you know that this is the Race in Medicine series, part 3 of a 3-part series on race in science, technology, and medicine this year. If you haven't been with us before, welcome. This is a class as well as a lecture series, so some of you may be faculty or staff, and we welcome you. You're free to participate in the chat, and we will take as many questions as we can. We do prioritize our undergraduate students. Before we get going today, I want to thank our co-sponsors. We have many units at Stanford that participated in funding this, as well as in choosing speakers and inviting them and helping us with all kinds of things. So we're very grateful to all of those co-sponsors. We always do a land acknowledgement at the beginning of each session. We acknowledge that we, Stanford University, sit on the ancestral land of the Muwekma Ohlone tribe. This land was and still is of great importance to the Ohlone people. So we acknowledge them and honor them and make visible our university's relationship to them. Now, next time we are going to have a session that's a conversation between two people, Dr. Takesha Cooper at UC Riverside and Dr. Shashank Joshi of Stanford. They're both psychiatrists, child and adolescent psychiatrists, and they'll be talking about race, culture, and mental health. So that will be our last session for the year, event number 30, for those of you who have been with us the entire year. And I'll let Jasmine do the real introduction here, but I just want to say what an enormous pleasure it is to have this mother-daughter session today with Dr. Andrea Reid and her daughter, Dr. Jasmine Reid, who has been your teaching assistant and my colleague throughout this entire wonderful series. So I'll just remind you to keep your mics muted. Undergrads, please put your full name on Zoom and leave your video on, especially if you're going to ask a question. This time especially, we always let people send questions directly to one of us if you don't want to speak your question out loud, but since Jasmine is part of this session, please send them to me instead of to her this time so that I can ask them for you. Just say that you can send it in private chat and just tell me that you want me to read it aloud. And as always, not only in this session, but in every session, please be respectful and kind. So, Dr. Reid and Dr.-to-be Jasmine Reid, you're on deck.
Thanks so much, Paul. It is definitely kind of odd, but also exciting to have my worlds merge in this way, because it's not every day that you get to introduce your own mother. So it is my deepest pleasure to be able to introduce and welcome Dr. Reid to this session of Race in Medicine. So Dr. Andrea Reid is Associate Dean for Student and Multicultural Affairs and the Director of the Office of Recruitment and Multicultural Affairs at Harvard Medical School. Dr. Reid is also a hepatologist and the Director of Diversity and Faculty Development for Gastroenterology at the Massachusetts General Hospital. After graduating from Brown University, Dr. Reid came to Harvard Medical School and earned her MD in 1988. She completed internal medicine and GI training at MGH and then joined the MGH staff. During her tenure, she co-chaired the Internship Selection Committee, directed the Gastroenterology Fellowship, was Associate Director of the Multicultural Affairs Office, and taught at Harvard Medical School. She also earned her master's in public health from the Harvard Chan School of Public Health and was deeply involved in the Boston community at the time. From 2009 until 2020, she was a gastroenterologist at the Washington, D.C. VA Medical Center. She's held several titles, national titles, including chair of the GI training examination for the American Gastroenterological, there we go, Association, and chair of the AGA Task Force on Under-Represented Minorities. Her clinical and research interests include racial disparities and medical education. She is a frequent lecturer on liver disease and medical education. So Dr. Reid will be giving a short talk followed by a discussion between her and me, and we'll then open up the discussion to our students for Q&A. So without further ado, please join me in welcoming Dr. Andrea Reid.
Well, thank you very much, Jasmine, and thank you for the invitation to share a little bit about race in medicine, and not just race in medicine, but racism in medicine, and they are inexorably linked, and a little bit about what I'm now doing at Harvard Medical School. I'm going to talk to you for about 30 minutes or so, and then we'll have a conversation, and I hope that people will ask lots of questions because I have a lot to share. So I'm just going to share my slides here. I have no disclosures for you today. So I'm going to talk about race in medical education, our turbulent push toward equity. And this is a funny slide. This is actually tells you a little bit about how I got into the work that I'm in. I grew up in an area of Columbus, Ohio called the Hilltop, and it's a working class part of Columbus, Ohio, which is, you know, sort of a hard scrabble area with a lot of individuals who were working really hard and barely making it, barely making do. It's also the area where the Columbus jail was, as well as the Center for Juvenile Delinquency. The Hilltop is known for several things, but not known for making doctors. At the time when I was in Columbus, Ohio, I learned about racial disparities, but I didn't really know what they were. And one of the most important things that I remember being taught or learning, probably through media, was that the life expectancy of whites was tremendously higher than that of Blacks, especially Black males. So that back in the 60s and 70s, when I was growing up, the difference between a white woman and a Black man in terms of their life expectancy was 20 years, with Black men being expected to die much younger than whites. And nobody was really talking about why this was a problem. It just was. And also I would hear about, well, Blacks have higher rates of hypertension and heart disease and stroke and amputation of their limbs and diabetes. But again, no one was really talking about why or how you eradicate those differences. Around the same time, I became aware also of the tremendous difference in Black women and white women in terms of infant mortality as well as maternal death. And that's the second slide you'll see here, is that the maternal death rate on this logarithmic scale is consistently higher for Black women compared to whites. And we now know that this is not specifically related to economics, because wealthy Black women are more likely to die in many cases than poor white women in childbirth. And then the third thing that became very clear to me was that when I was a kid, my mom was a psychiatric nurse, and she got Psychology Today, and I was fascinated by Psychology Today. And I remember reading articles that, again, spoke of the difference in mental illness and psychological disturbances amongst various races. But again, no explanation as to why, it just was. And that was my introduction to health disparities. No answers. So I went on to medical school. After going to Brown University, I went to Harvard Medical School. And I thought at Harvard Medical School, that was where they were going to start to really explain to me why these disparities existed. But unfortunately, it wasn't until I got to residency, and largely driven by the residents, not the people teaching us, that we really started to talk about disparities as being something other than acceptable, and something that could be explained not by biology, but by social determinants of health. And I have these pictures up here just to show you that I was indeed pushing for equity against the tremendous void. This is me with a little yellow circle around me. And as you can see, I am in a field, and that field does not look much like me. I was one of very few residents of color at Mass General at the time. And on the right is me during my GI fellowship, where I remained the only Black individual for the entire time that I was at Mass General, until I started to bring in fellows when I was the program director. And now there are 6 of us on faculty in a department of over 50 physicians. Well, as I said, for me, it really was always a question of why. It wasn't what. And I think that for many of you on this call and for others, the question of why disparities and what we can do about them has come to a head this year in the context of the COVID-19 pandemic. And I don't want to belabor the fact that you all already know, which is that the rate of COVID-19 was higher and has remained higher amongst people of color, but the most dramatic difference has been in hospitalization and in death, where Black and especially American Indian, Native, and Alaska Native populations have 4 times the hospitalization and almost 3 times the death rate of white individuals. We know that this is based in the social determinants of health, which you've already, I understand, talked a lot about, and includes things like economics, access to food, access to housing, schooling, education, and the like. But it's not just the death rates and the hospitalization rates that have been different. It is also the economic impact of COVID-19, the devastation of Black and brown families, Native Americans, African Americans. These are pictures that I pulled just that really reflect that desperation, not just because of disease, but because the downstream effects of the disease in populations that are already marginalized because of social determinants of health really cannot be overstated. In the context of that pandemic, there is another reckoning that occurred. And we know that right around the height of the COVID-19 pandemic, the world really watched in horror as George Floyd was murdered by Derek Chauvin, the police officer that knelt upon his neck for over 9 minutes as he called out to his mother, and others screamed for him to stop. People watched this and said, how did this occur? But the reality is that George Floyd wasn't the first person murdered by police, even in Minneapolis that year. There are others. And then around the country, people finally began to understand that there are real disparities in terms of the interaction between people of color, especially Black men, and the police, and with white citizens as well. As we think about the murders of Ahmaud Arbery and Breonna Taylor and Elijah McClain and others who had died at the hands of police, or at others who thought themselves to be able to police these individuals. And very few times has anyone been held account. So individuals from around the country got together, they marched, they talked, they screamed, they tried to make a case for changing the police, even as we think about the impact of racism in the setting of the COVID-19 pandemic. So it's really the juxtaposition of these 2 pandemics that led to the White Coats for Black Lives organization, a student organization asking for individuals in white coats, those who work within healthcare, to kneel down for 8 minutes and 46 seconds on June 5th, 2020 in solidarity. And these are some pictures from around the country. I'm sure it happened at Stanford as well, just as it did at my institution, saying that Black Lives Matter, that racism is not a difference of opinion, and that racial bias and racism is a public health crisis and drastically impacts the healthcare system. Enough is enough. Let's do something about it. But I ask you, what did the kneeling represent really? And I think this is a critical jumping off point for our conversation about race and medicine. It definitely represented horror at what people saw. It was the video. No one would have knelt down without that video, which is horrific. But it was horror at what they saw and discomfort with what they heard as they heard George Floyd not only say, "I can't breathe," but as he cried out for his dead mother and then joined her in death. It was disbelief that this could happen in broad daylight with individuals around screaming, saying, "You're killing him," with the kind of arrogance that was apparent in that video. It was sympathy for his family, recognizing that a family that loved an individual had lost their individual in the most graphic and horrific way. It was definitely solidarity with other white coats, individuals wanting to, link arms and say, "We are in this together. We in healthcare are not going to stand for this any longer." And for some, it was outrage at the systems that perpetuate racism, many systems that they themselves had never thought about, but had accepted these disparities that I talked about that I became aware of as a child. But really, did the medical establishment finally wake up to its racism, that which is internalized within medicine? And that's what we're going to talk about now. Because the reality is COVID-19 was predictable. The impact of COVID-19 on Black and Brown communities is predictable. Why? Because of the racism that is built in to the fabric of our country and in the healthcare system as well. Now, most people are aware of the Tuskegee syphilis experiment, and I understand you've already talked about that, where 400 Black men with syphilis were withheld treatment so that others could learn, a government-sponsored study that occurred over 40 years, that they could learn the natural history of syphilis, even when appropriate treatment was available. But that's not the only case, right? It has long roots, but there were other things that came well before that. You know the story of J. Marion Sims, who used slaved women, given permission by their slave owners to operate on them and perfect his GYN techniques on individuals with no anesthesia so that he could then do them with anesthesia in white women. You've heard of the Mississippi appendectomy, where eugenics and forced sterilization occurred on a regular basis. And a lot of this is detailed, if you're not aware and want to learn more, detailed in this book called Medical Apartheid by Harriet Washington, talking about the dark history of medical experimentation on Black Americans and from colonial times to the present. A dark read for sure, but one that is critical if we really want to talk about racism in medicine. We know that the impact of this long history of racism in medicine still bears fruit today, because the individuals have been experimented in for a very long time, experimented on, kept out of clinical trials and other things that lead individuals to say, what now? What's going to happen to us now? What has changed that's going to allow us to be prioritized and our agency to be appreciated and respected, even as we're dying of COVID-19? So you're aware of the Tuskegee experiment, and maybe you're aware of medical apartheid. Some of you may be aware, but I want to tell you about another impact of racism in medicine that continues to have long-standing implications, and that's the Flexner Report from 1910. The Flexner Report was very important, and this is Abraham Flexner, who is credited with being the father of modern medical education. And what he did at the behest of the AMA, the American Medical Association, as well as the Carnegie Foundation, was that he went and visited all the medical schools in the country and said that medical education should be refocused around the scientific method, that education should occur at academic institutions, not these for-profit organizations or institutions, medical schools that were proliferating at the time, and said that hospitals and medical schools need to make tremendous investment in medical education. Some of that money would come from foundations as well, in their admission standards, in their faculty, curriculum, and in their facilities. So these were the good parts of the Flexner Report. He also proposed that there be population-based standards that would determine how many medical school spots would exist. However, minorities would not be included in that population standard, so that even though there were increased numbers of people of color, there would not be increased medical spots. And in particular, he said that the practice of the Negro doctor must be limited to his own race. Now, white physicians could work on Black patients, but Black physicians could only work on Black patients. But that Black medical schools as they currently existed, he said, in no part they do not make any contribution of value. So this had immediate implications. There were 7 medical schools for Black physicians to be at the time, and 5 of those 7 closed in very short order. The only 2 that persisted were Meharry and Howard Schools of Medicine, which between 1940 and 1968, the start of the Civil Rights Movement, educated over 90% of Black physicians. They received their training at Howard or Meharry. Why? Because they were excluded from white institutions, including my own. Harvard Medical School had admitted people in the 1850s. And within 1 semester, those 3 Black men that were admitted to Harvard Medical School were expelled by Oliver Wendell Holmes, who was at the time the dean of Harvard Medical School. And he expelled them because of outrage from white physicians and white students. So between 1950 and 1968, Harvard Medical School graduated less than 100 Black doctors over 100 years. And it wasn't until 1968 that they began to admit Black students in any significant numbers. 16 were admitted in 1968 in response to the assassination of the Civil Rights Movement and the assassination of Martin Luther King. So most medical schools were just like that. So between 1910 and 1968, there were two medical schools that were predominantly educating Black individuals. And there have been recent analysis to suggest that if those medical schools had been able to persist and to grow as the other medical schools did, between 27,000 and 35,000 additional Black doctors would have entered the workforce between 1910 and 2019. Think about that. How the population has changed, but medical schools were not considering the Black population or the brown populations. And that these individuals were excluded from medical education almost exclusively. And it's important to note that this still has implications because 0 of the 30 new medical schools that have opened since 2000 are located at HBCUs. So still, medical education for minorities has been very limited. So this is a time of reckoning, not just a time of reckoning overall, but a time of reckoning for my medical school, a time of reckoning for medical education in general. And in December, Harvard Medicine, our main publication, put out an entire magazine around this issue of race in medicine, confronting racism in medicine. And I'm featured in one of those articles where I do talk about the kinds of things that we faced training through Harvard Medical School, training in the hospitals, and it really doesn't reflect Boston specifically. This is a nationwide issue. And these are some of the things that they have learned from talking to students, talking to residents and alumni and current attending physicians. Harvard Medical School and others have under-supported pipeline programs. They've used race as biology and attributed healthcare disparities to race rather than racism and the social determinants of health. They've tolerated disparate treatment of students, trainees, patients of color, and guess what? Attendings of color as well. And there's been lack of recognition of the emotional and spiritual toll of racism on those individuals. There's a lack of feeling of belonging within the institution, which is very different, as you all know, from diversity, which is a number. Belonging is a culture, it's an outcome goal. And there's that really very, very clear disparity between the two. And there's been no faculty development until very recently, and a lot of it this year, about racism and the impact of race in medicine. And in addition, limited underrepresented minority faculty to teach our students, to model for the white students the impact of race in medicine. So let's talk a little bit about that lack of diversity within our medical institutions. This is AAMC data from 2018 and 2019. But if you look at the percent of matriculants to the US medical schools by race and ethnicity, you'll see that for Black individuals, they make up about 7% of all medical school matriculants. So recognizing that Blacks make up about 13%, 13.5% of the population, this is obviously a gross underrepresentation. And Latinx individuals make up about 6.2% of those in medical school. But when you look at the faculty and our Native American students, less than 0.2%. And when you look at faculty, it's even worse. So if you look at those individuals that are working to train medical students, both students of color, but also students that are in the majority, you will see that those numbers are even more stark. So there are only 3.2% and 3.6% of faculty are Black and Latinx respectively, and our Native American faculty much less than 1%. So this is the kind of disparity that we're talking about. And if you think about the Flexner report and the fact that Black and brown bodies have been used predominantly as parts of experiments rather than uplifted as educators, you can understand how this has a tremendous impact upon how people are trained now. And this is our pipeline. So when we look at the pipeline now over the last 40, 45 years, you can see that the numbers of individuals going into medicine has increased. For white students, it's come down a little bit. For Asian students, it's gone up dramatically. But for Black and Hispanic individuals, despite many, many efforts on the national level, this number has been largely flat from the 1980s. And there are lots of reasons why. Well, we talk about this pipeline, right? You cannot just decide you want to be a doctor. There is a pipeline through which you have to pass in order to get to medical education. And the drop off in those individuals that say, I think I want to be a doctor, I want to take care of people, that occurs as far back as elementary and middle school. Why is that important? Because in order to go, think backwards. So in order to go to college, to take on a pre-medical curriculum, which is math and science heavy. There's lots of testing involved. GPA really matters. You have to come from a high school that is competitive and that you are really college ready from the beginning. Well, what makes you what gets you to a high school that's going to develop that? It's the skills that you bring forward from middle school. So this pipeline is leaky from very early on, as far back as elementary and middle school. Then in high school, you see a tremendous drop off in those individuals that think they want to do medicine. College is also a tremendous place of drop off. And Stanford actually did a study looking at their own students to see, of those that came in saying that they wanted to go into medicine, how many of them ultimately enrolled in medicine in medical school. And the largest drop off was among the students of color who came in saying, I want to go to medical school. So these are individuals that clearly came from high schools that made them ready for Stanford. It wasn't that they were failing out of Stanford. It was the reality that there are lots of things that allow you to persevere toward medical school. Some of it's interest in finding other things you want to do, and that's fine. That happens for everyone. But the ability to be supported through this pipeline to excel, to succeed, to do well on the MCATs, to maintain a high GPA, there are many, many detours to that. And this is what has led to a very, very steep drop off between college and medical school. Now, once people get to medical school, most of those individuals are going to graduate and go on to residency training. But a very small proportion of those individuals are going to be able to persevere to the point of being physician leaders and able to influence the pipeline, as well as the prevalence of Black and Brown individuals within our medical schools. So this is the direct impact of racism, not just in medicine, of course, but in our society, and the impact that it has on education, I'm sure you have already talked about. But it's more than numbers, and I just want to highlight a couple of things. One is that minority women and LGBTQ medical students describe discriminatory comments, public humiliation, and sexual advances much more than white students do. In fact, they also talk about the curriculum and how it harms them, that race has been used as biology, that there's limited faculty of color to both inspire them, but also to support them through their journey, and unchecked bias within the lecture halls and on the wards. It's been allowed to persist for too long. And if you read any of these articles and look in the comments and see who is saying these individuals are snowflakes, they don't know what it's like to persevere, they shouldn't be in medicine, those are comments that are being made in 2020 and 2021 at a time when people are saying we're reckoning with racism. It is alive and well in the academy. There's also the hidden curriculum, and you'll hear a lot about that for those of you that are thinking about medicine, but even beyond that, that hidden curriculum is that which is observed and taught, but not in the classroom. And there is racism and bias within that hidden curriculum that is absorbed in very real ways. There's also bias in assessment. There have been multiple studies that have shown for medical students and for residents, bias in assessment, where women and people of color are more frequently described by their personality while assessments of men focus more on their skills. Harvard Medical School, I'll talk about it in a moment. We've been looking at issues like assessment, and we recognize that there are differences in how people are assessed based on implicit bias. Minority patients are more likely to be underserved in our country and may prefer and benefit from the care of underrepresented physicians. But as I've already shown you, those numbers are exceedingly small and they have limited access to them. And in addition, there's been limited faculty development on racism, implicit bias, and microaggressions. Those of us that do this work have been extraordinarily busy since the big kneel, right, of June 5th. But the reality is, we don't know if that actually changes behavior. For many people, it is performative, just as their kneeling was. So let's talk a moment about implicit bias, because it does directly impact patient care. This is one study I wanted to highlight, it's relatively new, where they actually looked at dentists and their clinical decision-making on how restorable teeth are. And they presented these patient vignettes, just changed the race, everything else the same, patient presentation, everything else is the same other than the race of the patient. And they also had them doing implicit association tests. And what they found was that the recommendation for a root canal, which is restoration versus extraction, was dramatically different, whether the patient was presented as white or Black. Everything else the same. Now, this has not only been shown for this study, but it also has been shown in terms of cardiac catheterization, pain medications in the emergency room, EKGs for chest pain, and the like. It absolutely has a direct impact. Though JAMA put out a tweet saying there are no racist physicians, we recognize that racism has its roots in, it has its impact on all of us, including those of us that treat patients. So how does it contribute to healthcare disparities? That's a critical question. So let me take you down a pathway, something that is stated a lot within medicine, and show you exactly how this has an impact on your medical education for those of you thinking about going to medical school, because if you hear this, you may observe the way that this implicit bias plays out. So pathway A says Latinx patients overstate pain. That is provider implicit bias, something that they have begun to believe, sometimes because of what they've seen in the hidden or heard in the hidden curriculum, but also other things that they may have observed, right? They came to some judgment, so they make a judgment about patient care and decisions about what that patient should get, because we believe that Latin patients overstate pain. So because they believe that patients overstate pain, they undertreat and underevaluate their abdominal pain, which leads to disparities in pain treatment. You are already aware of that pain study that where medical students from 2016, the study was published in 2016. You remember that study where those students said that they thought that Black individuals had thicker skin and less nerve endings. Well, those individuals that were first years in that study, the Hoffman study, they are now interns. So they are treating patients independently. They are responding to patient pain. So if you believe that, then what's the implication when you actually get to the point of caring for patients? The same is at work here. So that you overstate, they overstate pain, I believe they overstate pain, I undertreat, leads to disparities. And this is where an interpersonal bias becomes a structural bias, because those individuals are not getting the care that they need. And those people who are deciding to perpetuate these disparities are also training the next generation of students. Pathway B says they overstate pain. So I spend less time because I don't believe them. Patient feels unheard and undervalued. This interrupts that communication and trust with patients and impacts the patient's engagement and adherence to therapy, increases patient no-shows, and impacts the adherence to provider recommendations, because I don't believe that that provider cares about me as an individual, which subsequently perpetuates these disparities in health. So the interpersonal, again, becomes structural. I'm not going to spend a lot of time on microaggressions because I know you've talked about that, but implicit bias and microaggressions are so linked that it does warrant just mentioning that when we have these implicit biases, which are these negative attitudes that we develop through socialization, we all have them, we internalize them, we have implicit biases about specific identities, the way that we've decided to make sense of the world, and lots of inputs is to put people into these buckets. We then develop microaggressions toward those who hold those identities, which, as you know, are the result of our own biases. They are ignorance, they are rude. It is rudeness, it's ignorance, it's devaluation of individuals based on the implicit biases that we have. So these are just a few of the kinds of things that students and physicians of color deal with all the time. Nurse, can you find me a doctor? It doesn't matter if you have doctor on your head. I had circumstances where I've been mistaken for everything but a doctor, even with a badge, even dressed as a doctor. Someone asked me once whether or not I was there to fix the broken air conditioning when I came in a white coat to do an endoscopy on somebody who was bleeding out. Because again, in that person's mind, there's a place where I belong, and in a white coat, it must not represent that I'm the person coming to fix the bleeding. Do you speak English? For people that do not appear to be white Americans, this happens all the time, as does, are there any doctors from America here rather than where you must be from because you look differently? There are many other microaggressions that we could talk about. So I've given you a little bit of a background in terms of racism in medicine and how it's been presented over time, the impacts of implicit bias and microaggressions on students, both in assessment, in their interaction with the medical establishment. One of the things that has happened and has taken up a lot of my time this year has been the Harvard Medical School response to George Floyd's murder and the COVID-19 pandemic as we begin to think about this fight against racism. And I came back to Harvard July 1, but in June, our Education Policy and Curriculum Committee decided to commission a task force and put me as the co-chair of it for when I started. And it's called the Program in Medical Education Task Force Against Racism. And the task force objectives was to perform an in-depth internal scan of medical education at Harvard Medical School with no sacred spaces, identify areas where racism is embedded in the experience, identify areas to incorporate anti-racism education, make concrete recommendations and priorities to combat racism, and develop an ongoing monitoring process and reporting structure to address racism and discrimination, because it is vastly underreported. So our task force, we got together as an executive committee and identified the areas where the work needed to occur. That's assessment, how people are graded, admissions, how they're admitted, student affairs, how they're cared for as students, curriculum, what they're taught, faculty development, who's teaching them. And we had, with a broad coalition attempt to really get representation from faculty whose voices had not been heard in the past, we had over 30 students and 150 faculty volunteers volunteering to work on these various committees, and submitted report of our total product is over 75 pages long. But this is an example of some of the priorities that we put before our dean and our medical EPCC, the Education Policy and Curriculum Committee, that we must increase underrepresented faculty in all aspects of the clinical of the experience, both in the hospitals as well as in the medical school itself. Institute comprehensive, mandatory anti-racism training that is tailored for the degree of engagement that an individual has with the students, so that those that are that are in charge of curricula, those that are teaching in the classroom, must be aware, but also be in a place to check their own biases. That the institution must provide money, faculty, and staff to carry out these recommendations and coordinate anti-racism efforts, so that everybody's not doing their own thing, that it's coordinated, because our students they're not just at the medical school. We have multiple hospitals that they go to, and much of the bias that they experience is within the hospital environment. So we need some way to coordinate it, and it cannot be on the back of those that are already doing this work and have been doing it for free because they care about it. And that the medical school must begin to compensate work in diversity, equity, inclusion, and belonging, not just financially, but recognizing it for promotion. We also need to develop anti-racism competencies for faculty and students, so that we're not just saying this is an add-on to your educational experience where we're going to talk about racism, but that it's embedded in what we expect, not just of the students, but of the faculty as well. And that we must anchor the implementation of these many, many recommendations made by these subcommittees, not in my office, the Office of Recruitment and Multicultural Affairs, not in HR, but within the leadership of the medical school and the hospitals, so that there is skin in the game for those that make decisions and that determine the culture of the institution. So I mentioned my office, and I'm coming to a close, but I mentioned my office, the Office of Recruitment and Multicultural Affairs. And this, in fact, has been there since 1968, when they started to admit Black students. And many medical schools have this kind of office, others have nothing. But my office focuses on the recruitment and support of medical students who are from groups that are historically underrepresented in medicine, who identify as LGBTQ+, and who are or are economically disadvantaged. And we approach our work through an intersectional lens. Our goal is not just that our students would come to Harvard Medical School and survive, but that they would thrive, that we would support their professional and personal growth, that we would provide opportunities for them to lead and to step out of their comfort zones, sharpen their skills, and engage with like-minded medical students around the country, that we would support that work. In addition, we would become integral, of course, to the diversity, equity, and inclusion activities within the PME at Harvard Medical School. So hence, I was asked to lead that task force. But this is what I spend a lot of my time doing. If you look at this bubble here, our office is in the middle, but this is all the different things where we are asked to engage, including obviously the task force, but recruitment, admissions, supporting our student affinity groups, now faculty development, student development, anti-racism work in the curriculum, mentorship for our students of color, so that they don't just get through here without anyone caring about whether or not they get what they want, and individual student support. Well, how's that going? Well, I love this quote, because we would not have received this quote before this year, because we're now embedding anti-racism discussions and discussions about implicit bias, microaggressions into the first week of medical school. We asked them, what might you do differently because of the racism in medicine session? And one of the students said, I understand my complicity in racism and the importance of challenging biases as a healthcare professional. I've said this before, and I'll write it again. Learning about racism for medical professionals is simply not optional. It's no different a responsibility for us than learning about biochemistry or anatomy, which I could not have said it better. I think that this student recognizes, and many students recognize, that they are on the forefront. And if the medical education is going to change, it's going to change with them learning from early on that biases exist, that we can eradicate them, that work is left to be done. It has nothing to do with kneeling down. It really is about what happens when you stand up. So what does it mean to be an anti-racist? You talked about it, I think, within the context of this discussion before. I put this up because this was adapted by a surgeon and has been proliferating around medical centers around the country, because we recognize that medical institutions are saying we want to be anti-racist, but you can't have an anti-racist medical institution unless you have anti-racist individuals. And anti-racism is not cultural competence, it's not tolerance. It is actively working to dismantle racism. So we are asking individuals to map themselves on this graph and say, where are you? Are you still a denier that racism is a problem, and avoiding those hard, difficult conversations and staying with individuals that are like yourself so that you don't have to really engage around these difficult topics that I mentioned today? Or are you in that learning zone where you're starting to ask questions? You know you're going to make mistakes. You know it's going to be uncomfortable, but you also understand that your own privilege, whatever kind of privilege you sit within, that's, if you are able to ignore racism, that is a privilege that you need to release. And now you move into that growth zone where you say, I will sit with my discomfort. I will ask those hard questions. I will educate my peers about how racism has harmed our profession, and I will speak out when I see racism in action. The goal, of course, I tell individuals, is you want to make it where it's exceedingly clear that no one should ever feel comfortable being racist in your presence. So finally, not everything that is faced can be changed, but nothing can be changed until it is faced. This is my favorite quote from one of my favorite authors, James Baldwin. And as it relates to racism in medicine, this is where we are. We're beginning to face it. We will see what's going to change. So thank you so much for your invitation, Jasmine, and for your attention. This is, anyone who knows me knows that Jasmine Reid is my favorite woman in the world. And this is 2-year-old Jasmine, who was already organizing people, places, and things. And she has not changed, as you have seen through the work of this, lecture series. She is absolutely my heart, one of my 3 amazing heartbeats. And thank you so much, Jasmine, for allowing me to share what I do.
Well, thank you. I was not expecting that. So I'm a little teary-eyed. It's fine. It's end of the quarter. But I will say there is a real pleasure in being able to hear someone like you, who I know so well, speak about topics that, you know, articulate with the series, but that kind of articulate with a much broader sort of body of literature, and with, you know, different communities. And so it's a real pleasure and a learning experience for me as well. So I would love to just offer you a few questions to maybe kick off our Q&A. And of course, Paul will be moderating the student Q&A. So as we get questions, students, please do submit. So I want to start actually where you began, which is really your formation as a doctor and the context in which you were working. So one of what I think is perhaps one of the most sobering statistics that we listened to in the podcast Beyond the White Coat, which was pre-assigned for today, is that in 1980, there were about 1,000 Black medical students. And in 2020, that number has only increased to 1,500, with most of that increase being attributed to Black women. And that's out of what, 22,000, 23,000 available seats in medical school each year. And so you obviously came into your own as a student, as a physician in the 1980s. And I know we've talked a little bit about what that experience was like, but I'd love for you to reflect a little bit about, you know, what it actually looked like for you to start implementing anti-racism within this really hostile context. And of course, I'm hoping that you'll speak a little bit about your experience working in a community care center, in a clinic, and the work that you did with patients who were, by every other physician, sort of turned away because they were assumed to be, you know, pain management seeking rather than physically ill. So if you could speak a little bit about your experience, that would be wonderful.
Well, let me just say that, I told you a little bit about what Columbus, Ohio was like, and that there were very few mentors that were, that I could look to, individuals in medicine. My mother was a nurse. And like I said, I was reading Psychology Today as a child and knew that there were opportunities to be engaged with science in a way that would be transformative for individuals. And I loved my pediatrician. That's really, I think, where it started, was that I thought anybody that can make you feel better when you feel terrible, that individual can be emulated. But this person in particular, Dr. Benjamin Cohen, who was an osteopathic physician, he was so caring and so loving and so warm that I wanted to be like him. And I decided to be a doctor when I was 8 years old. But there was also encouragement along the way. And that was through my high school biology teacher in 10th grade, who said, "You have got to leave. Like, you've got to go." He was one of my very few Black teachers that I had growing up. I would apply through the A Better Chance program. I was a Better Chance scholar, went to a boarding school in Middleburg, Virginia, as one of very few Black students, experienced racism that I had never seen, like old money racism, and ultimately really considered that just a stepping stone to where I wanted to go. And that was to leave Columbus, Ohio. So I went to Brown. And it was really there that I found my people, because there were a very large number of the Black students there that were interested in medicine. And we are all still supporting each other to this day. I came in with good skills because I had had that 2 years at a boarding school to really hone my leadership skills as well as my study skills. So from when I was at Brown University, I was running the Black Pre-Medical Society and saying, we will all make it. And that's really where I got the commitment to lifting others up, was really during that time at Brown, where I said, you know what? We can make it. If we link arms, we can make it. And so I went to Harvard Medical School. I told Jasmine the story that I almost didn't go, because one of my first introductions to Harvard was that picture of the flag, that people haven't seen it before. A flag was being used to trying to be used to stab a gentleman that was walking through City Hall Plaza during the busing riots, the busing demonstrations in the 1970s. And it became a very, very landmark picture. I think it won a Pulitzer Prize. But that was my Boston, to me, was that picture that I saw when I was in middle school. But I came to Harvard Medical School because when I came to visit, there were other students who were doing the kinds of things I wanted to do. That idea of sort of being linked to individuals who cared. And the dean of ORMA said, "You will thrive here." So that's how I ended up going. I ended up staying in Boston despite wanting to leave, largely because of Jasmine's father, who I met when I was in medical school, but also because the chief of medicine at Mass General Hospital said, "I want you here." And the impact of having a leader, really a sponsor, not just a mentor, but a sponsor saying, "I will make sure that you thrive," was critically important to me matching at that institution. It was there, however, that I really got to see racism in a new way. I experienced more racism as a resident and as a trainee than I ever had as a student. You're a little bit more protected as a student, but it was there that we had a significant sickle cell population, and they would come in the emergency room over and over again with pain. And I would hear people say they're overstating pain because I don't see objective signs of pain. High heart rate, writhing in the bed, they are not in pain. Now, I had known people with sickle cell growing up, very few, and recognized that how people experience pain and how they show pain can be quite different. But there were attendings, the people over me, the hidden curriculum was these individuals, who were mostly Black and brown individuals, overstate their pain in their drug seeking. They wouldn't just model the behavior to them, they would say it out loud. And at one point, I remember someone wanting to give a person with sickle cell crisis, give them a shot of saline instead of narcotics to treat their pain. There was nowhere for me to go with that knowledge. Right? Who do you go to when your leaders are the one that are perpetuating bias and harming patients in the way that I think I showed you? But in fact, I started taking those individuals into my clinic. I couldn't influence so much what happened on the inpatient side, but I could make sure that they had a place to land when they were out of the hospital with someone that understood, that cared, and that believed them. So that when they came in the emergency room now, they had a doctor. They weren't just coming through the ER. They were Andrea Reid's patient. And that makes a difference.
That's so powerful. And I just think about, it's so sad that there were these necessary loopholes for you just to help someone feel dignified and feel like they belong, as you mentioned, which is a cultural thing rather than just a numbers thing. So thank you for that service and for being an example to others who have come after you, like me, right? Who recognize that it is important to make pathways for those who may not have access to power. So I'd actually love to dovetail a little bit with that question, where you're sort of recognizing there's this hidden curriculum in your medical education. And I will say that growing up, racial disparities was a buzzword in our family. Like before I knew how to say gastroenterology, which, as you've already seen, is a very hard word for me still to say, I knew what racial disparities were. And I think that's a thing that I treasure. And as your child, I didn't necessarily understand why this was unique to our family, right? That we were talking about these structural issues. But now as an adult and as an academic peer, I would love for you to talk a little bit more about why you decided to, when you had finished your medical education, you decided to get a master's in public health to explore issues like racial disparities. Why did you think that a medical degree was not quite enough for the work that you wanted to do?
That's a great question. And it's important to mention, I guess, that I didn't actually get my MPH when I was during medical school. A lot of people do. They'll link extra degrees to their medical education. I was not that person. I actually did it after doing 3 years in the lab, working as working at Mass General Hospital in a basic science laboratory on hepatitis C, and really seeing the difference, though. So hepatitis C is more prevalent among Black populations. However, Blacks make up less than 5% of those included in clinical trials. And I became very concerned about the fact that you're making decisions about how to treat individuals, but not including those that are most affected with this disease. And I would see, again, this sort of speaks to the same stuff I had been thinking about before. And I realized that my interest, even though I enjoyed the lab and the ability to have reproducible results over and over again within the lab, clinical research is a little bit different than that. But I realized that what I really cared about was speaking truth to power, yes. Also clinical trials, clinical research, epidemiology, statistics, you have to understand it. So I went back after I already had 2 kids. I was already an attending physician. I went back part-time to get my master's in public health, to give me that the bandwidth to be able to have these conversations, not just from a place of my own personal experience, but also as an academic. And so it influences a lot of what I do, though I'm not doing predominantly research. That educational piece, especially the work that I learned from Dr. Kamara Jones and others that have done work in racial disparities, it really does influence who I am and what I do today.
Great, thank you. So I'll ask one more question and then we will start opening it up for students. I have lots of other questions, but hopefully some students will be able to bring some interesting topics to the conversation. So the last question I'd love to ask is really about coalition building. So in the podcast that was assigned today, the featured physician, Dr. Acosta, talks a lot about how to be an anti-racist medical institution, it requires institutions to sort of think beyond the typical partnerships that tend to accommodate and to that students tend to reach out to in their medical education, that physicians might be part of. So I'm wondering if you could talk a little bit about what it looks like to forge community partnerships that are outside of like the typical in medical education, and how those community partnerships within Boston and maybe even within your context of having worked in DC, what those partnerships enable when it comes to rethinking what medical education can be.
Well, I totally agree with Dr. Acosta, that you cannot talk about dismantling racism in medical education when, in fact, you do not communicate with those individuals that have borne the brunt of it. So if we go back to COVID-19, the idea that we would create a vaccine and try and get individuals to get the vaccine so that the numbers would be higher, there was real effort to do that for all of the companies that made it, but not realizing that the depth at which there was mistrust around what this that the medical mistrust was not misplaced, it was earned, and that you dismantle medical mistrust with building coalitions. You go to the community, you don't ask them to come to you, you ask them what they need, and then you bring the resources to them. It's a very different way. Institutions like my own have for so long sat upon a hill and said, we have the resources, come to us and we will deign to give them to you to increase your health. But we've done very little to actually address the social determinants of health that impact health much more than access to medical care. And there was an article actually in the Boston Globe specifically about Boston, looking at where people of color in Boston get their care. It's not that they face all kind of barriers, but there's medical institutions on every corner in Boston. And yet those institutions reaching back and saying to the communities, what is it that you need? That has been very slow to happen. The way that institutions thought about building coalitions is, well, we'll put a health center there and then we'll staff it. Now that's an important part. But that's not. Did I lose you, Jasmine? You there? I think she froze.
I'm sort of here. I can hear you.
You froze for me. No, that's okay. Okay, good. But you have to do more than just put a health center, right? You have to figure out what is it that these communities need. So Harvard Medical School finally this year is starting an office called the Office of Community-Centered Education. Well, what does that look like? That means you bring individuals from the community to help them shape the medical education of the students. You decide that community coalition building is an important part of education. And you say to the students, this isn't an add-on. We are going to create opportunities for you to benefit the community, to learn from the community, but you will not take advantage of the community. And so I'm so excited that this year, our Racial Justice Coalition students, they decided to do just that. When it came time for them to go away for the holidays, before they left, they said, we need to think about who we are as a neighbor. Harvard medical students as a neighbor. It's not about the health centers. Right now, there's an organization that focuses on community development, that there are families, because of COVID-19 and beyond, that are desperate for money, for food around the holidays, for clothing, for heat. Heat is very expensive. It's a resource that is not given freely. And what they did for the first time was they put their efforts together. They reached out to faculty and other students and raised $12,000 for a community organization called ABCD for their emergency fund, with no ability to control how that money was going to be utilized. That's an important part of coalition building. We are doing something for the community that does not benefit us directly, and that we listen to them as to what they need rather than trying to build it and tell them to come.
Well, Dr. Reid, I have a bunch of questions for you in my queue here, and I'm going to start with one that follows on what you just said. And I think you partly answered this, but maybe you have more to say. The question is, how might we change the come to me attitude as a community when the institutions are the ones with the resources? Is this only something that can be changed by the institution or at the institutional level?
I think it has to happen at the institution. As you said, the institution sits upon the resources. But again, if all these institutions are saying that they want to be anti-racist, we have to show them. And this is one of the things that I spend a lot of time doing, saying why, how you've been a bad partner and the kinds of things that we can do to bring the resources back to the community. What does that look like? And it's not just the individual doctors. There's always going to be individual physicians and medical students who want to work in the community. We have to make the case to the institution that not only should those students be able to do that and get credit for it on an academic side, but that they should be resourced in such a way to benefit the community, right? Not to go study it, but to go and benefit the community, and that is scholarly. It can be scholarly. It absolutely should be valued and should be undergirded. And it should not just be the students of color who are the ones going into communities of color to ask them what they need. The institution needs to come with its hat in its hand and say, we have not been supporting the communities in the way that we should. And how can we do better? and but the institutions have to see that there's a responsibility, and we have to link that to anti-racism. That's the key, and that's what I mean by holding the recommendations of our task force. The accountability can't be in the offices here. It has to be here. It has to be in the heads of the hospitals. It has to be metrics and dashboards that they are judged against. And if that occurs, they will build the bridges that need to be built. But if it's not centered in how they're evaluated, then it won't occur.
I really like that point, and can you expand on that a little bit? How do we get that to happen at the high levels of
Ah,
institutions? You know,
well,
it's easy to implement amongst the faculty, but when you're talking about the highest level administrators, who evaluates them? How do we get them on?
ah, their board does. So if you, I had a friend recently who was looking at a job at another institution. He's at an academic center doing very, very well. And he's looking at another institution. And I told him one important piece of advice. I said, listen, do not go there if diversity, equity, inclusion, and belonging is not built into the way that that CEO is being evaluated. If it's not part of how the board is judging the leader, because we know that this stuff flows downhill, right? If they're not being judged on it, then they will not evaluate, they will not prioritize it in the same way. And you can see what an institution values, right? It's your time, it's your treasure, right? It's your talent. Where do you put those three? If they're not including creating an inclusive culture with real metrics within the leadership, the way they're being evaluated, then it is unlikely to occur. And I think that it's really important for institutions to think about that. I look at some of the work that's happening in some of the medical institutions, what the boards are saying to their hospital leaders is critical, because they're now saying this again, like I said before, just in the educational realm, it cannot be an add-on to education. You have to actually say there are competencies around anti-racism that we're going to judge the faculty, how well they are able to teach it, and we want the students to demonstrate that they have these basic skills before they leave us. That is something we're going to build into our course competencies. It has to happen, but it also should be happening at the highest levels of our institutions as well. And they report to someone. Everyone reports to someone, and they report to boards.
Great. Switching gears, moving back into something you said earlier in your talk, I have a question. Do you feel like educators are the ones who have the largest impact in minimizing disparities in the pipeline to a career in medicine?
Uh, you know, this is such a difficult thing, because the answer is yes on some level, that but it's much broader than let's put some educators of color within these schools to inspire students. It's much broader than that. So if you look at some of the under-resourced schools, and the reason that they don't put out students that are ready for college, ready to succeed in college, for many of the under-resourced schools, resources for schools are tied to taxes, right? They're tied to the economics of the community. So if you have poor communities and low tax base and the schools are under-resourced, often the individuals teaching the students have not even trained. They have not trained in the areas that they're being asked to teach. So you don't have master teachers in those schools teaching those subjects. You don't have books that are up to date or other resources for those students that allow them to excel and to expand upon their skills. So it's not just the educators in the classroom, it's the resources that they are given, right? It is the environment. Just as there are social determinants of health, there are tremendous social determinants of education. And we cannot separate those by just putting more students of more young faculty of color in these classrooms and saying, okay, go inspire, or go find the next doctor within that school and let them know that they can make it. That's much too trite, but it is a critical part of the pipeline development, is having those individuals that really believe in the students and believe in their potential, because these students that are dripping out of the pipeline have tremendous drive and tremendous potential. However, it is amazing how quickly that can be stripped away based on where they live, how they live, what they're exposed to, who's in their communities, the support within the community itself. It has very little to do with ability.
Great. Well, so here's another one. And I want to sort of combine this one with one of my own, which is I really liked what you said about the difference between a mentor and a sponsor.
Mhm.
And I'd sort of like to hear you expand on that concept a little bit. But the student question is, how do you think the leaders and people in authority can begin to bring more Black faculty and instructors into the leading space?
Again, this is where you have to hold people accountable, because there are a lot of biases. I didn't talk too much about bias, but one of the biases they talk about in admissions, which is highly prevalent whether you're on Zoom or whether or not you're in person, is this sort of like me, same as me kind of bias, which is you see the individuals, you recognize where they've come from, you've gone to the same schools, you have some of the same shared experiences. Those individuals tend to be rated higher, even if everything else is equal, than individuals that are different than the evaluator. And so when we talk about leaders, leaders tend to perpetuate that within their spheres by allowing, promoting those individuals with whom they feel great affinity. And again, that's a very well-known rating bias, but it's also a bias in who gets promoted and who does not. And so when the key thing is having leaders saying, let's say the leader of a department, the leader of medicine, for instance, at our institution, saying, I want each department to have an equity director within that department. Those individuals need to be paid. Their role is that they will look at issues of equity within our institution. They will sit at the table of leadership, and they should be a diverse group. They're not all people of color, et cetera. And each department had to go through that churning of who's going to be this equity director. How are we going to put some resources toward helping them to do what they need to do? And how are we going to incorporate this person? Because in almost every case, except probably my own, the equity director was not already a leader within this, was not a senior leader within the department. Again, but it was established at the top to say, this is how we need each department to think about their own metrics. How are they going to measure themselves on making progress? And one of the ways that you make progress is having an inclusive and diverse leadership. Well, very few places have diversity at the top, but they all report to someone. And many people have said, well, we'd like to be diverse. We'd like to increase our diversity, but they're not out there. They don't exist. We don't know how to find them. You cannot sit on that excuse. If your leader is saying, we will provide resources to make sure that your search is broad. We will not close a search until there are diverse candidates, viable diverse candidates that we are seeing. That's the way that you bring about diversity. The other thing is that NIH has said, we have a big pile of money. It's called the FIRST grant that they just put out. You may have heard about that. We are going to give to these 12 institutions, $10 million for hiring of diverse faculty, right? All of a sudden, the question is not, oh, can we find them? Now the money's there. If you get that money, you have to have a plan for how, because it's very, very targeted. Now that may not diversify who's teaching the students, because for most places, it's going to be a lot of basic science faculty, but there's a role for that obviously as well. But again, when you put the money with the resources and tag it to meeting a metric, making improvement in a way that is definable and measurable and time bound, I think that's where you start to make movement.
Let me turn to a different kind of question. This student asks, as someone looking into navigating the world of medicine and potentially attending medical school, what do you think are the best ways or strategies that we can use individually to hold our peers and even higher level mentors accountable with the limited power we have as medical students?
Thank you so much for that question, because I think that this is a tremendous issue that individuals that we talk to about bias, they'll often say, well, why didn't the student say anything to me? Why did they come to you? Or why are they writing about this anonymously? People forget the power dynamic that exists within any institution of higher learning, and especially within medical school, because those individuals are going to evaluate you. That impacts the residencies that you get. That impacts, impacts your future in a way that is very, very tangible. And so students often are reluctant to report. What we tell students when they come in, what I've been telling my students early on, is that you have the ability, if you don't want to confront someone that exhibits bias directly against you, or that you observe that you're an ally, in fact, there are individuals that are willing to go on your behalf. And I think that is really critical. But if you want to be empowered to bring it forward, I will go with you if that feels like the best form of support. If you don't want to say anything, but you just need emotional support, that is okay as well. That the onus is not on you to fix the system. However you feel to engage with what occurred, I'm here to support that. That is really what our office does. And I've had all of those circumstances this year where individuals have wanted to advocate for themselves with some backup, where they've wanted to advocate for themselves and tell me about it afterwards. And other times where they've said, I don't have that fight me. I'm not interested in that. There is a ability to have dialogue that needs to be driven by the person that has experienced either the microaggression or bias. They have to have agency to decide how that is moved forward. And we take our lead from them. But I think that's really critical for someone deciding to come into medical school. Recognize things are going to happen. You'll let many things go because it's just not worth your energy focusing on. And then there'll be other things that really you feel the need to elevate them. You need to have support to be able to do that. So personally, myself, as if I were going back to medical school, I would not go to a medical school that did not have an office like the office that I run. Because I do think, having just met with our seniors last night, it is so critical to have that level of support when medicine is so narrow in so many ways. It's very provincial, and the diversity push that I talk about, that turbulent push to equity, it is not straight. And though a lot of people knelt down on June 5th, the marches have stopped. The comments that people are making about some of these articles that have come out about race and racism in medicine, and you really see the kinds of things that our students are still having to push through. It's a slog, and we support them in whatever way they want us to support them.
Yeah. Well, that brings me to the question, where is it? Where did it go? Hang on. Yeah, this is a nice one. What is the best development or the most inspiring that you have experienced since beginning your work? Work meaning either the medical field in general or specifically working formally in anti-racism?
Well, I can tell you for sure, as a liver specialist, so I'm a hepatologist, which is a liver specialist. It's a subspecialty of gastroenterology. And for sure, two really dramatic things within my professional field have made the difference. The first is all oral therapy for hepatitis C infection. I spent a lot of my time working up individuals with hepatitis C cirrhosis for liver cancer and liver cancer for liver transplantation. And we unfortunately had very limited therapy that was only about 29% effective in Blacks, about 58% effective in whites. Took a year, made them very sick. It felt like they had the flu for an entire year. But they pushed through, and most of them would relapse or not respond at all. And now we have all oral therapy that over 90% of individuals, independent of their ethnicity, independent of ancestry, independent of whether they have cirrhosis or not, we can clear them of hepatitis C. Now, there's still access issues with regard to that treatment, but that is by far been the most dramatic change and most fulfilling thing for my career as a liver specialist. The other is the approval of colonoscopy for the screening of colon cancer, which occurred when I was a fellow, or just after when I joined the staff around 2003. Medicare approved polyps, and it's led to a dramatic decrease in the incidence and prevalence of colon cancer. That being said, the guidelines were just updated over this last year, and especially this last week, where now colonoscopy not only will be approved, but it'll be approved for individuals as young as 45. There's still equity issues, right? It's having something approved on the national level and having agencies say that this is available is different than getting individuals in to get them done and completed. But we continue to push through. But it was a dramatic change in how in the fight against colorectal cancer that occurred in the early 2000s, and we continue now to fight against early colon cancer, younger and younger individuals, especially individuals of color. With regard to the anti-racism work, I have to say, I've only been back doing this as something I get paid to do. I've been doing this work, as Jasmine said. The issue of disparity has been a part of my life since before I was a medical student, as I sort of laid out for you. I think that one big development is that I'm now paid to do the stuff that I used to do for free. To be perfectly honest, my time and energy can really focus on these efforts. And I have to say that, really spearheading that task force and getting it through and having such a broad coalition of faculty who really felt like they had no voice within the medical school, many of them that are on the lower part of the promotional scale, being able to get those individuals together to work on these topics of assessment, faculty development, curriculum, student affairs, and admissions has really been, it's been a seismic change, I think, for me in believing what the power of our internal community at the medical school, and also recognizing that the work is just beginning because it's not funded yet. We said that was recommendations is one thing. Implementation is a completely different science. And how the medical school is going to actually implement these recommendations, organize them in a way that the highest yield, those, not the easiest things are done first, but those things that will actually change culture, that those are highlighted. Being a part of this work is going to be, though it has its frustrations, it's really exciting. And I really do think, I'm cautiously optimistic that we can move the needle.
Great. I just gotta, Jasmine's having connection problems, but Ocheze, you ready to talk? Ask your question, please.
I think Jasmine wants to turn on the light.
Yeah.
Yes, you are sort of fading.
The sun's going down, it's getting dark. Hopefully you can still see me. I'll turn on the light.
Go ahead, Ocheze.
Hi, Dr. Reid. Thank you for your talk. It was super informative. I really appreciated it. And I wanted to ask you a little bit about your experience, kind of holding the door open behind you, so to speak. You kind of talked about, your intentional efforts to increase the numbers of Black staff, bringing on fellows and things like that. And so I kind of wanted to hear your experiences with that, if there are any challenges in that process.
Oh boy. Yeah, I'm sorry, I'm just getting this thing to plug in the light. Hold on one second. There's always challenges. And I actually, right before this call,
changes that may have come about, faculty or people with hiring power in their institutions to sort of bring about that sustainable diversity.
I'm sorry, I missed the latter part of your question.
Oh, I'm sorry. I asked if you had any recommendations for faculty or other people who have hiring power in their institutions to kind of bring about like that sustainable diversity in their hiring practices.
I think that one key thing is that sustainable diversity requires, and again, we want to move beyond diversity in numbers and you have one person come in and two people leave, that we really have to think about how do we encourage individuals who are highly talented to bring their whole selves to the institution? And how do we provide for them such experience that they would not think about leaving, that they don't want to leave at all? And it is a hard thing to do because, as I said about our students and our faculty, they are unicorns. They are beloved and wanted across the country, and that by the time we recruit them, we should already be working on retaining them. And that this is a critical thing. I think that the reason that there is this revolving door is that you bring people in and everybody goes, yay, look at us. We are 20% or 30% people of color. And then you realize that that is not the totality of the experience. You have to dig deep to make sure that those individuals have mentorship, that they are on a pathway toward success as they define it. And so one of the things I've been doing this year for my chief is actually meeting with our faculty. I redesigned our faculty development form and said, what are you focusing your energy on? And does it align with who you want to be? Because if it doesn't, that's a really important thing for us to focus on, is where do you want to go? And how can we support you to get there? That doesn't mean people won't leave, but it makes it a lot harder to leave when the leadership is saying, I want your success. Like, your success is our success, however that's defined. And that's not generally the way that academic institutions have done things. So that's one big piece. The other big piece that I would add is that I think, and that gets to that part of belonging beyond just the numbers, is making sure that we are considering for each individual that we're bringing in, that we're considering what their pathway to leadership is. Isn't that a really different way of thinking about things? Saying, I'm bringing you in to be a leader. And you may not be ready to lead in a lot of areas right now, but what can you lead? What can you contribute? And then what are the steps that I, as a more senior person, can take to help pave the way for you? So within the professions, one of the big things is getting people involved in meaningful committees, not relegating them to the committees that look just at things that you think that they're good at, but actually helping them to stretch and to expand, putting them on the committees where actually there is some power. And really yielding space for them to stretch and to grow. So that's one of the things that we've done a lot of at ORMA, my office, is that for the students, I actually put that in the mission statement. Our goal is to help you to become leaders, not just to be great doctors, but I want to make space for you to lead. That means that we will fund it, that we will encourage it, that we will help you in whatever way possible. So our medical students, first-year medical students, just had a conference called the Empower Conference, had over 700 attendees, 700, from middle school, high school, college students, and those that are in post-bac programs, 700 individuals. Do you know they had faculty from across the institution, including alumni? Now, what do? Well, those students are now going on to their clinical experience in the hospital. How do we then take something that occurred? We don't ever want that to be a one-off. How do we say, if a student wants to continue this, how do we then undergird them? Because they have the same work as everyone else. They have the same requirements for assessments as everyone else. How do we sustain this effort that is absolutely a fabulous pipeline program, but not have it be on the back of our Black and brown students who envisioned it, but cannot be the people to sustain it? Because we want them to be great. I told them, I don't want you to come here and hobble out of Harvard Medical School. I want you to stay in the training programs if you so desire. But if you do not, I want you in the top training program to get you where you want to go. And if that is the mission, then our first year students can't be continuing to sponsor on their own a conference for 700 people, which will only grow in the coming years. So that's just one very tangible example. I sent the comments that came from our students, from the people that participated in the conference. I sent it to the dean. I sent it to the dean of students. I sent it to the dean for medical education, and I sent it to the dean for the university, as well as the dean of admissions. I said, this is what our students did. How are we going to support this next year?
Great. Well, we're unfortunately out of time, but before everybody gets off, first I want to thank you for an amazing session. This is one of our very best, but I have one special announcement I want to make, which is to share this screen and say that soon-to-be Dr. Jasmine Reid, for her work in this series, has received the Stanford Alumni Association Community Impact Award for 2021. That she knew about. What she didn't know is that she has also received the STS Directors Award for advancing social justice in STEM. So we are so happy to have you and your mother here, and I cannot thank you enough for all the things that you have done for us this whole year. And with that, we'll have to let everybody go, but thanks to Jasmine and thanks to Dr. Andrea Reid. And Dr. Reid, if you'll stay on for just a minute, we'll debrief for a minute after everyone checks out.
Thank you, students. And thank you, Paul and STS. This has truly been one of the highlights of my academic career. So thank you for making this such a valuable experience.
Thank you to all the students for being here. It's been wonderful to share with you.